Good afternoon, everyone. I thank NIOM and Karnataka Ophthalmic Society for this opportunity. So I'll be talking about pearls for IOL exchange. So when do we think of going into this? Mainly when there's a visual disturbance, when an IOL placement has gone wrong, you have a capsular bag issue, patient is dissatisfied, there is an IOL decentration or a tilt, or in cases of your endophthalmitis. So in any of these things, basically the patient is unhappy and the whole it's a very bad scenario which you are stuck in. So the thing is, when you'll plan to remove a single piece in cases of your dislocations, a multifocal you'll think to remove if it's causing like a more of a glare aberrations. The three piece again if your IL power has gone wrong. A refractive indication if there's been a wrong biometry or a wrong IOL being placed. If it's initial, you can manage. If you can place like give glasses and you can manage it, it's well and fine. If not, you can. It's best that you plan to try to explant or exchange it within 3 months. The usual visual disturbance is again the glare halos, especially in case of your multifocals or trifocals. The square edge IOLs or the high refractive index, which give you a positive dysphotopsia. Delaying in to wait again for these conditions, again. Becomes what happens is like the IOL gets again stuck. There will be synechia formation, which again when you're planning for to remove it or to exchange it, again it becomes like a different circumstances to go in. So the earlier you plan earlier if you plan for an exchange or an explant, it's more the better. Inappropriate IOL, if it is placed, especially you have a rent and you're planning to put it in the sulcus, which can cause you like a more of an inflammation or irritation. Then again, if there is a smaller size of your IOL which is placed, or if you are again planning to a reposition. So these are all like some of the indication when there is an IOL has been placed inappropriately. Dislocated, especially this is the most common indication, especially if one is in the bag, one is in the sulcus, one haptic again like it is damaged. So the strategies again, if you can try to secure it, it is well and fine. If not, if the bag is compromised, it's better that you remove it off. So it's always better that you evaluate from the start, like what can determine the best possible things. You see like what is the symptoms the patient is approaching you with. This reduced vision, is it more of a blur, is it more of a glare, the discomfort level. And then you go about like how you're going to evaluate it, especially in terms of try to identify where there is the unexpected error has gone wrong. Try to see the refraction. You can see like how what is the leftover residual refraction which is left. See in the slit lamp the capsular status, if an YAG has been done, if the capsule is compromised, or is it calcified. The position of the IOL, is it already like decentered or tilted. The corneal health, if at all, again you're going to plan for something secondary. In the imaging wise, you see the OCT for any macular edema or any retinal disorders. See the topo for any kind of a corneal aberration which is present. A scan or the biometry to again to repeat and get an accurate accurate biometry if at all you're planning to go again. Assess your risk assessment. So if at all like you have to see what the patient wants. If at all the patient is actually dissatisfied, it's better that you can go according to what the patient's complaint is. Always balance the risk. There is always a risk, like when you're thinking again, when you want to go in, you want to remove or you want to reposition it, there are a lot of risk involved. There might not be like the same condition like what it was before. So you need to address it. You need to talk to the patient. You need to explain them the plus and minuses of what can happen. See the timing. The more earlier you're planning all this, it's better. The more later, the more complication or the associated things are going to be late. Check the retina, and if at all you're planning for the surgery, make sure that like what equipments and the instruments you need to plan for the surgery is already ready with you, and you be well prepared with your plan A and plan B. So let's see how to manage it. One, you craft like another new 6mm incision. You plan to remove the whole IOL, do a vitrectomy and go with another 3 piece or a second IOL where it's possible. So this is again like a courtesy of Dr. Uday Devgan, which is possible in case of your acrylic hydrophilic lenses, where you try to twist and remove. This is usually possible if you can try to get it into the AC, put dispersive visco to protect your endothelium, slightly, increase your entry wound, which you can try to refold it and remove it. To free the existing IOL, it depends on how long it's already been there. First, try to get the dissection plane between the IOL and the bag. Use dispersive visco adequately. Free the haptics with the visco dissection or with your iris forceps. So here in this video, you can see me trying to get a plane. So this is very important. The take home would be the lesser manipulation what you can do is better, because you try to just try to take off the whole IOL, you will try to be in a mess. So you try to get a plane, try to dissect it. You try to get a plane which you can try to slightly rotate the IOL and get it into the AC. Once if it is there in the AC, you read the haptics, it's much more easier where you can try to cut it out and remove it. Because with that, otherwise you are again trying to do much more damage to the other ocular structures in the same time when you're trying to plan that. So here, once I've dissected, I've got the plane, I'm trying to get it into the anterior chamber. Once that is there, I've cut it, and then I'm going ahead and putting a secondary IOL. So to cut, either you can use the Vanus itself, or you can have the IOL cutting scissors. You can use it completely, cut it into two different halves, or you can cut it into like 2/3, and then you can try to remove it. This is usually, again, it's very easily possible if you can just try to slightly extend your inner lip of your 2.8 millimeter incision of your phaco. So it's the take home would be to use dispersive visco in a good amount so that you can protect your endothelium. So this is again a video of Dr. Uday Devgan, which he's used. This is not, I have not tried this technique, which he's tried to fold the IOL and taken it. Can I just extend it?
Just continue.
So yeah, more of your acrylic lenses can be refolded. Use of dispersive, slightly extend your incision to 3 to 3.5. This is like the new future which is there. This is like an invention by Dr. Neha Dulakia, which you can use like the new scissor into your phaco probe, which you can cut the IOL into two halves, and it's easier to remove it. The foot control, since it's been in your hand, it's much more easier to use it. So you can cut it into multiple pieces, and then you can remove it. Even you can, in case of your hard cataract, to get the initial chop to divide it, it's been used right now. So the summary is, you always weigh in the factors influencing your decision. Keep your patient's visual expectation at par. Keep your safety checklist, how you want to decide, and what decision you want to do, and what technique you want to go about it, and the timing when you want to go in. The more earlier, it's always better. More than 3 months, once the synechia sets in, then to remove it, it'll be a little tricky. So I conclude by telling, can I just extend by
continue slides, last slide.
Yeah, so my conclusion would be, like, if it's possible to reposition it, you always try to do it. Always give realistic expectation to the patient so they know what is there. Refractive IOL exchange, you can plan for within the first 3 months. Most difficult part of an exchange is when you try to free the haptics from the capsule. So that always keep in mind the instruments required and how you want to thread about these cases, and choose your best technique according to you and what you feel comfortable. Thank you for your time. Thank you for your
Thank you, Dr. Shamanth. I think before continuing for discussion, I request Dr. Deepti Joshi to come to the stage. She is one of the prolific pediatric surgeon from central part of the Karnataka. So I think the take-home message, I think I've been doing this IL exchange. One of the most innovative by Dr. Neha Dulakia is just to get this phaco, take out the phaco tip and touch this IOL cutting forceps into the phaco probe. So there are two advantages with this instrument. Either you can trying to cut while doing the phaco, you can cut the nucleus into 3 pieces. That this has been tried. But the most important thing is the most useful instrument to cut the IOL. Yeah. The thumb behind IOL exchange, this is my experience, always cut into 3 pieces. I keep telling you should not cut into 2 pieces. Rather, cutting into 3 pieces using a high molecular viscoelastic is the thumb. I think any comments from the audience for IOL exchange? Any comments? Okay, thank you. So I invite the treasurer of our state society, none other than Dr. Ilan Kumaran. He'll be talking about the management of dry eyes in cataract surgery.
Thank you, sir. At the